acid can turn to beta-phenylethylamine and also tyrosine into octopamine. Both octopamine and beta-phenylethylamine are very strong, extremely strong proteins to the brain. Understandable? So not only those threats I powerfully represented, but also on the other hand, formation of these neuromédiators which are false that will bring to accomplish damage to the brain. Understandable. That's why in majority of cases, hepatic encephalopathy is easily that goes to comatose state and becomes the reason for fatality. Understandable. Can you hear me?
Yes, ma'am.
Now, a couple of words about liver cirrhosis. What is liver cirrhosis? You can see and compare that glossy liver pattern, which was in the beginning of this lecture, and now what is this thing, the ugly view of this liver is. That's liver cirrhosis. Liver cirrhosis is a chronic disease of liver characterized by decreasing number of functional normal hepatocytes, then diffuse overgrowth of connective tissue and becoming stony, decreasing oral diameter of sinusoids and decreasing in its growth size, pathological regeneration of parenchyma, formation of pseudonodules, then the reconstruction of parenchyma and vasculature inside the liver. So, types of the etiological background of liver cirrhosis is versatile. That's the alcoholic preface, the porta or fatty, then Linux cirrhosis, that is the Linux cirrhosis, when the reason is alcoholism. Etiology. Ethanol is a degradation product that is the acetaldehyde influence on hepatocytes extremely in a toxic way. So they bring to decomposition, necrotic events, and this continuous necrotic. So we are talking about the chronic alcoholism. These things will be accompanied with the chronic inflammation, with the chronic abnormal proliferation, which ends with this pattern you saw. Biliary cirrhosis. Biliary develops due to impaired bile flow. It could be primary and secondary. Primary biliary cirrhosis is believed to be autoimmune. Although the antimitochondrial antibodies are usually found. Then the secondary biliary cirrhosis due to obstruction of the bile duct by the stagnated bile or the complement or a tumor. So from inside, from outside, doesn't matter. Understandable. Biliary cirrhosis, what? Because bile has destroyed, devastating action onto the parenchymal cells, the any cells, even on its hepatocyte. But the result is coming, of course, necrosis, and followed by inflammation. Continuous inflammation. Here we're talking about the chronic inflammation and cirrhosis. Non-alcoholic steatohepatitis also is one of the reasons. It is a consequence of obesity, usually. Then post-necrotic, because of viral impact, also autoimmune destruction and the toxical or chemical impact. Metabolism, glycogen storage disease, alpha-1 antitrypsin deficiency, then hematochromatosis, Wilson disease, etc. Cardiac cirrhosis also is there due to the right-sided heart failure, which is chronic heart failure. Then other reasons also are there. They are all summed up in the cryptogenic cirrhosis. That is the pattern. This one is pattern of the normal hepatocyte arrangement and abnormal. Look at this. That's normal. This one is abnormal, and you can see that there was approximately full count the substitution with the with very rough fibers. Fibrine fibers and collagen, the harsh collagen fiber. I'm talking about substitution with a connective tissue, abnormal connective tissue, which will revolve everything into the strong pathological way. Scar tissue is coming to be formed. And this slide shows in much more detail. Look at this, that is the normal histological pattern. This one is when liver cirrhosis is there, what happens? The differences are very apparent. Here, what can you see here? Processes. Normal processes disappear, and the cells are erythematous of roundish form. Then the most changes, pathological changes happen in the sinusoids of this region. So we have a narrowing of sinuses, then we have a shrinking of them because of excessive formation of these fibers. Scar matrix is coming to be formed then. This one, I showed that. This one is the ethol cell, or that is a quiescent stellate cell. Normally, it provides the deposition function of vitamin A. But when inflammation happens, so that immediately changes its orientation and becomes like myofibroblast, which will work for the sake of sclerotization. And many other adjacent pathological events eventually will bring to scar and or stony liver formation. Liver cirrhosis, clinical signs and symptoms. So I'm not going to dwell long on this thing because you study the same thing in the ID, okay? And in this picture, everything is quite understandable and clear. But the most things, clinical threats are the portal hypertension. Portal hypertension, pay attention to the types of portal hypertension, pre-hepatic, intrahepatic, and post-hepatic. It is very, very important and going to be included in your exam questions. Understandable, and definitely to understand what is the portal hypertension and which situation is considered to be hypertension or the normal tension. Normal tension when the pressure is not exceeding 5 millimeters of mercury column. But clinically significant portal hypertension starts to be when it increases more than 10. Portal hypertension's consequences increase that what? First of all, ascites. That is the number one clinically observable thing. Ascites with the caput medusae, with look at this, development of collaterals, hemorrhoids, caput medusae, esophageal varices. Then portal systemic shunt formation also brings to entrance of ammonia and other toxins into the blood circulation, and liver encephalopathy will happen. Then splenomegaly comes as a result of the inability to handle that much blood. Hepatomegaly then also goes into splenomegaly as well. But the splenomegaly on its own is threatful for the elements. First of all, RBCs are going to be decomposed. Anemia happens. Then leukopenia because of WBCs, and thrombocytopenia because of platelets. So, pay attention. So the portal hypertension can become the number 2 cause in the bleeding. Understandable. Number three, that is intoxication, and others also you think of that. These are the clinical manifestations aside from pathophysiology. Now, this slide is also very catchy, that brought our attention by ascites. Ascites has many different pathways of formation. Cirrhosis brings to ascites in evolving of these different pathways. Portal hypertension is number one. That is because of increased hydrostatic pressure and filtrate pressure will bring to leakage out of the blood plasma into the abdominal cavity. Then sinusoidal hypertension, increased lymph production, and its percolation into the peritoneal cavity will make crying liver. That's also ascites. Then hepatocyte failure will accompanied with the hypoalbuminemia, low oncotic pressure, and effective plasma volume gets down. Why? Because water goes into tissue, also into the abdominal cavity that to replenish the ascites. Next, alter steroid hormones metabolism. Alter the steroid metabolism. That means that some hormones are coming to get decomposed in the liver. Now, when the liver failure is, they will stay higher and for a long time. That first of all, that refers to steroid hormones, and aldosterone is one of them. On the other hand, aldosterone is coming as a result of RAS activation. Understandable? Why? Because the portal hypertension provides the abnormal return of the venous blood to the heart, which is followed by the abnormal or less cardiac output. Less cardiac output will make a less perfusion to the kidneys. Less perfusion to the kidneys will activate the renin-angiotensin-aldosterone system, bringing to excessive aldosterone formation. But this aldosterone formation won't work to normalize the situation, but will exacerbate the ascites. Understandable. And the last show in this whole to accomplish this defect is by bacterial peritonitis because of increased capillary permeability. Understandable. Bacterial peritonitis happens because of less bile into the gut. So the bile cannot control, and there is an overgrowth of microflora. These microflora will bring to excessive formation of gases. So flatulence will happen, and this excessive pressure will make bacteria of these intestinal bacteria pass into the blood, providing the bacterial peritonitis. And this bacterial peritonitis, of course, will be accompanied with the increased capillary permeability, which also will help in ascites. Is it clear?
Yes, ma'am.
Okay. There are some slides you'll go on your own. This one, serum ascites albumin gradient. But considering that ascites is not only because of liver failure, there are some other premises clinically manifesting as ascites in many situations. There is the necessity to find out the real pathway of its formation. Understandable. And in its puzzle, this index is of great matter. Understandable. It is very important. SAAG, that is the difference of albumin in the serum serum of the plasma albumin minus the albumin found in the cytic liquid, in the cytic fluid. Understandable? And depending on that more or less value, we can judge about the possible pathological pathogenetic base. As you see, there are many pathogenic bases. If the thing is less than, first of all, a cytic protein, the gradient is the difference is more than 2.5 gram per deciliter, that is the easiest pathogenic background. It includes congestive heart failure, constricted pericarditis, then early blood carrier syndrome, then IVC obstruction, sinusoidal obstruction syndrome, etc. When it comes less the difference, it means in acyclic liquid in fluid, the albumins are growing up. It means that the situation for the permeability of the membranes is going to get increased, and that's why that makes clinical much more severe situation. It is accompanied with the biliary leak, the nephrotic syndrome, the also pancreatitis, the peritoneal carcinomatosis, and tuberculosis. That is the most impacted situations, understandable, when the difference between the albumin in the plasma and in the acyclic fluid is minimal. And in between them, the situation when the acyclic fluid is less than 2.5, that corresponds to cirrhosis, latent bacteria syndrome, massive liver metastasis. Clear? Is it clear?
Yes, ma'am.
This slide shows how do we have the exacerbation. And there are so many vicious cycles. This one is one of them. And the last thing today I have to talk about, that is the causes and classification of jaundice. As you see, pre-hepatic, intrahepatic, and post-hepatic jaundice will differ, but the reasons are completely different and versatile. As I will say in a in a gross manner. So the pre-hepatic mostly are accompanied with the hemolysis, excessive hemolysis. Of course, as a result, we will have indirect bilirubin increase and severe intoxication because of these this one is very toxic to the brain. Lipophilic state. Next, intrahepatic. Intrahepatic premises are coming where from? These are coming from liver damage, hepatocytes damage, and leakage out of the bilirubin from the cellular interior into outside. Then also drug-induced cholestasis can bring. Next is post-hepatic. Post-hepatic mostly is accompanied with the obstruction of the bile flow from the gallbladder into duodenum. Understandable. And these situations are mostly accompanied with the direct bilirubin increase. And the last thing, hepatocellular failure, the symptoms and signs. Look at this. Impairment of nutrition is because of impairment of metabolic processes. Manifestation is going to be fatigue, anorexia, indigestion, weight loss. Fever. Fever is dependent on necrotic events. That is a result of that. And leakage out of toxins into blood, and also bacteremia, which also possible to be. What is the manifestation? Let's shift glucocytosis and inflammation. Jaundice. jaundice, hepatocytomatic necrosis, and colorization of skin and mucous membranes. Endocrine impairments, that's impaired hormonal metabolism, decreased hormonal, which hormones will stay upregulated because there is no way to get the control in the liver. That first refers to the steroid hormones. Okay, so we have increased of aldosterone and estrogen. Because of this thing, decreased libido, testicular atrophy, gynecomastia in men, diabetes mellitus and secondary hyperaldosteronemia. Diabetes mellitus is because of what? Hyperglycemia, postprandial hyperglycemia. Clear? Because from the beginning we were pointing to that the inability to form glycogen will make postprandial hyperglycemia and preprandial hypoglycemia. Then comes the hemodynamic disorder, increased production of vasoactive substances, production, and on the other hand, no way of decomposition will bring to diffuse vasodilation, compensatory increase of cardiac output. Edema ascites, we have told a lot about this thing. Pathophysiology. Pathophysiology is caused that's a very bad odor, smell, is caused by the accumulation of toxic and having smell things, toxic things. These are ketones, first of all, then mercaptan, and dimethyl sulfate, etc. Unpleasant smell for mouth. Liver science and neuropathies, impairment of the blood circulation will be accompanied with what? It will be accompanied with clinical signs are coming, tender, ectasias, spider veins, then palmar erythema, red skin on the palmar aspects of the hands, and hemorrhagic diarrhea, the bleedings, and the DIC syndrome also is highly highly probable with high likelihood because of impaired synthesis of components of hemostatin and impaired inactivation of active proteins. Understandable? I can hear you.
Yes, ma'am.
Can I be sure that you will work out and devise? Understandable? Devise the whole week's lecture. Clear? So I have provided lecture, share with all students of all the groups. I provided as much as possible powerful explanation, and if there were some questions, you can apply to me. Is it clear?
Yes, ma'am.
Okay. So that much. We have provided one Monday day. Clear? That was done
Yes, ma'am.
instead of Mondays. So missed our classes, lecturing classes. That's all. Bye for now. Respond, please. Respond.
What happened, ma'am?
I'm asking, bye for now. And there was no any response.
Yeah, yes, ma'am. Yes, ma'am. Bye bye.
Okay, bye.